A warning, this podcast talks about sexual assault. Imagine you're at one of the country's biggest hospitals for a gynecological operation. While you're under general anesthesia, so unconscious, you're also being used as a training opportunity. A medical student is told by your surgeon to do a vaginal exam, to put their hand in your vagina so that they can identify where the cervix is. But you didn't agree to be examined by a medical student. And in fact, when you wake up, you aren't even told that you were. This happened. Now, the Health and Disability Commissioner has released the findings of an investigation into the processes around informed consent in obstetric and gynecological theatres at Auckland's North Shore Hospital. The investigation was spurred by the complaints of one whistleblower, called Registered Nurse A.
She's a very determined person, and she says, somebody that you hadn't consented to having their hands in your vagina trying to find your cervix, would you want to know? And she says, I would want to know, and I would want my children and my granddaughters to know. So she has a very strong sense of what's right in terms of informed consent.
Stuff Circuit investigative journalist Paula Penfold broke the story.
She wanted to describe what the process had been like, because it was a fight for her. And even though, there are aspects of the eventual finding that she's happy about, there are some that she's not. And so she wanted the story to be told in a fuller way than the report ever could.
Kia ora, I'm Gwen McClure, and on The Detail today, that story of patients who were examined or treated by trainee doctors and students without giving their consent, and still don't even know. Paula explains what went so badly wrong at North Shore Hospital, and how Registered Nurse A isn't finished with her fight.
So she was running the obstetrics theatres and working in gynaecology at North Shore Hospital, which was then the Waitemata District Health Board. So back in 2012, she noticed concerns around informed consent practices not being properly adhered to, and she complained then to the District Health Board. And it took her complaint seriously, it investigated, and it made some amendments to its policy, which was introduced in 2014, rolled out with new education and new training modules around what was explicitly required under informed consent. And she was happy with that. But then she had to take time out of work because of illness, and she returned to the hospital in 2018 and said that things had significantly deteriorated in terms of issues of consent. And on that note, we know what consent is in a general situation, but I asked her, what do you think consent is in this situation? She talks about wanting to know, having the right to know who's touching your body, who's going to be present, and who's going to be carrying out the procedure. It's quite simple to her. So she saw that the policies and guidelines weren't being adhered to again in 2018, and she had issues with the actual consent forms themselves, that they were presented as an almost fait accompli to patients, that they didn't really have a choice actually, and the whole point of this is that they should. And so she complained again to the District Health Board and experienced some quite significant fallout. And ultimately, with the support of her representative from the New Zealand Nurses Organisation, she decided in an almost unprecedented move to make a complaint herself to the Health and Disability Commissioner.
Can you give me some examples that she gave you of times when informed consent was not given or maybe even requested?
Yeah. And so there are very many. The nurse has a dossier of more than 40 cases of varying types of concerns, but because they have not been reported on as such at an official level, that's for another stage, that reporting. So for now, probably the two best cases to refer to are patient X and patient O. One of them was a situation in which a woman had been examined vaginally by a junior doctor, and she was already under anaesthetic. And then the house officer, who's a doctor in training, was told by the junior doctor to do the same examination.
Again. So an unnecessary for the patient
Indeed.
examination. Okay.
For the purposes of teaching, as the nurse describes it, so that this house officer could find out where the cervix was. And so she intervened and said, but there hasn't been consent. She hasn't given consent for this. And the junior doctor said of the house officer, but she's a doctor, as if that meant that consent was not required. So Nurse A's intervention meant that that second vaginal examination without consent did not take place. And in the Health and Disability Commissioner's report, she praises Nurse A for that intervention. Another situation was where Nurse A walked into the theatre to be met by a surgeon saying, oh, you're here, we'd better do it properly. And so then updated the consent on the documentation.
On behalf of the patient.
On behalf of the patient. And Nurse A says that if she had been allowed, as a part of the investigation, to go back into the DHB and find, those records, she would have been able to show that there were two different coloured inks used, i.e. that the consent had been recorded after the woman was already anaesthetised. Now, there was no finding in the Health and Disability Commissioner's report about that, ostensibly because the evidence was not available. As I say, Nurse A says it is available, she just wasn't able to access it. Yeah.
This is just from one nurse. I mean, do you think that it's broader than this?
That's a really good question, and that's the position that the Commissioner ultimately took, was that since, even the District Health Board and Te Whatu Ora ultimately had acknowledged that there were valid concerns, and that's evidenced by the fact that they changed their practices, since this was one nurse and one District Health Board, one hospital actually, one theatre ultimately. The Health and Disability Commissioner decided to undertake an investigation that was broader and systemic and find out what the consent processes were throughout the rest of the country. And so that formed, really a significant part of this investigation, and is partly why it took 5 years.
Okay, so what did this report find? What does the report say?
The report did not find a breach of the code, ultimately. And the reason that the Commissioner sets out for that is that she has chosen to take an educative approach to this, to finding fault, making many adverse comments, but not finding an actual breach. So she has made many recommendations to Te Whatu Ora around what it needs to do to get its informed consent practices up to scratch. When she started looking nationally at practices, she basically found inconsistencies that most District Health Board or Health New Zealand regions had specific consent processes in place, but there were variations around how it would be implemented, who should be asking for the consent. And so she wants a consistent process developed. She also wants an audit done of consent within Health New Zealand Waitemata, and a number of other recommendations that have essentially supported what Nurse A was complaining about. Nurse A, is disappointed that there was no breach found of the code. The other thing that she's disappointed about is that because the Commissioner chose to take a systemic look at the issues rather than really investigating the individual cases, the women who were subjected to these flawed processes still don't know. I mean, the District Health Board did do an investigation, but it's not clear at all whether the women knew. And it seems to me that actually they didn't. And so, and absolutely, in terms of the cases in recent years, they wouldn't have known. So there'll be women listening to this or reading the reporting who might go, oh, well, I was in an obstetrics theatre around that time. I wonder if that's me. And to Nurse A, this feels like another undermining of their rights, that they can be discussed in great detail, potentially, without ever having been told that this was them.
You do sit there questioning it, right? I mean, these would be thousands and thousands of people who just don't know.
Indeed. And
what recourse do they have?
Well, one thing that they can do is apply for their records. And Nurse A encourages them to do that. If they think that this might have been then, or even if they're just interested, they're entitled to apply for their records, and that might bring this to light. So that's one thing. But the other thing I think that ultimately, in a way, Nurse A has in common with the Commissioner is that she wants this to be a reminder not only to health professionals but to patients that they do have a right to informed consent. So Nurse A wants this to be a conversation, a reminder that those laws about informed consent exist, and they exist for a reason.
So what are those laws? What does protect us as patients?
The Health and Disability Service Consumers Code of Rights is really the anchor for informed consent and for how treatment decisions should be made in New Zealand. So it's called the Code of Rights, and lots of people will have seen it when they go to a doctor or they go to a hospital. There'll be a poster on the wall with 10 rights.
This is Monique Jonas. She's an associate professor in ethics at Auckland University's Medical and Health Science faculty, so she teaches ethics to medical students.
So the code has 10 rights that every single service user, every single patient has. And that includes a number of rights that are all about informed consent. So I guess the starting point is that all patients have the right to be treated with respect. And they have the right to effective communication. They have the right to be given information, and they have a right to make an informed choice and give informed consent. And it also lays out a few details around the kinds of information that a patient should be given. And that includes information about proposed participation in teaching. And there's also a particular right that's all about teaching and research. So whenever we're thinking about what a patient should be told, or when it's a choice for the patient, then we go back to that code. And then I guess the other thing to say is that informed consent is not just about patients agreeing to something. It's really about patients being able to make their own choice. And that means sometimes patients will refuse things, and that's all part of informed consent.
But North Shore Hospital argued that asking for consent would, quote, seriously impair the delivery of clinical care and prevent the training of the future workforce.
One of the criticisms that the Commissioner makes of North Shore Hospital is that in large part its defences were around the fact that it's a teaching hospital, and that as such it was almost implicit, I'm paraphrasing, but that because it's a teaching hospital, of course teaching is going to happen on women, and that if you were on patients and if you were to seek explicit consent for every possible situation, then one of its arguments, defences, was that the patient might say no, and then that would interfere with training. That would mean an interruption to training. The Commissioner was very clear on that. That's not good enough. The purpose of consent is exactly that the women, patients, consumers, as they're called in the report, deserve to say no. They're allowed to say no. That's the whole point of it. And also the Nurse A questioned the research that was cited around that and said, in reality, most patients, when they have the circumstances fully explained to them, most will consent to it. The fact that they might say no is not a good enough reason to not ask them.
Monique points out that decisions without consent can be made in emergency circumstances.
There are provisions for doctors to make decisions based on what they think the patient would be in the patient's best interests. That's about serving the patient's best interests. That's quite different from, I guess, the context that we're talking about around teaching and trainees learning. So yeah, there are situations in which doctors have to make decisions for their patients. You can't just let a patient die because they can't decide. but that doesn't mean that you can involve medical students in treatment without a patient's consent.
You are involved, obviously, in teaching students, medical students. Do you feel that students leave their training understanding what informed consent is?
I think that when our students leave our training, they have a really good understanding of informed consent, of its components, and also of actually why it matters. So I think they really understand that informed consent is required to respect your patients, and they care about that and they worry about that. You know, they really think about what they need to do to ensure that everything they do with patients is consensual.
The North Shore Hospital story is particularly shocking, but unfortunately not entirely unique. The Health and Disability Commission publishes the results of its inquiries. Searching the keyword informed consent brings up more than 1,500 reports. Things like a fallopian tube removed without consent, a circumcision to which a man didn't feel he'd consented, a patient who came in for anxiety and depression and instead was given a breast exam that she says she cried throughout while repeatedly asking the doctor to stop.
So the Medical Council has looked at what is the definition here of, sexual contact between doctor and patient, and says that if it's performed without consent, then that is sexual impropriety, it calls it. But it's a discussion to have, isn't it? And I think it's a useful one around understanding the concept of informed consent. We're now at a societal level, we're kind of more well-versed in what consent means in a regular situation where somebody might be inserting their fingers into somebody's vagina. Let's not mince words. And so what's the difference when it's a doctor who does that without consent? So there is Medical Council consideration of exactly what circumstances, would be described as sexual impropriety. But I think there probably is more discussion that needs to be had around that.
Yeah, I think you've said it, but in any other context, we call that sexual assault.
Yes, and so that's why I say I think there needs to be more discussion around that. I mean, and this is why Nurse A intervened. That's exactly what she perceived it would have been if she hadn't done that.
But Nurse A's intervention cost her hugely.
She would complain and complain and complain. And, I've seen her correspondence. There's a lot of it. But she didn't feel that her complaints were being taken seriously. But not only that, worse than that, she started to become, I would use the word bullied. There was never a formal finding of bullying, but the behaviour she experienced sounds a lot like bullying to me. Where, for instance, in one circumstance, there was a letter from a surgeon professing to be on behalf of that surgeon's department, asking for her to be removed from theatre. And so she was initially, but with the help of her union representative, eventually she was reinstated. So rather than acknowledging and respecting her concerns, she really felt as though she was being undermined and disliked, actively discouraged from being able to voice those problems.
Which is obviously bad for her, but it's also doesn't speak to a culture where concerns can be raised on behalf of a patient and something is done about that.
Indeed, and that's ultimately why she decided that it needed to go outside of the DHB and Health New Zealand and to the Health and Disability Commissioner. And she explains how she had come from working in a background of sexual health with diverse communities. She'd been working for 14 years in that sphere and found informed consent processes really strictly adhered to, and was shocked when she ended up in obstetrics theatres to discover that they weren't, that they were paid, in her terms, lip service to in many situations. And the other thing that's quite interesting to hear from her is that, she describes herself as being older and experienced and had the guts to stand up to surgeons. But she says many nurses don't, but also many junior doctors don't. And so even if they knew that this was improper process, sometimes they wouldn't say so either because of that very hierarchical nature of medicine, particularly theatre.
Wow, I hadn't actually thought about that part of it. So someone performing an exam that they know they shouldn't be performing.
But don't want to say so.
In the report, is there anything about the culture of medical workplaces and how to change that culture to give nurses an environment where they can stand up to doctors or junior doctors, where they can stand up to more senior doctors?
I mean, Te Whatu Ora said in response to my questions that, in terms of workplace safety, it does provide, or attempt at least, to provide a safe place where staff feel valued and respected. And that's good, but if they do, then a lot's changed since Nurse A left. She went on sick leave and then she retired 9 years early because she was so disillusioned with what she was going through, the fight that she was experiencing. So I think, ultimately the report's suggestions around education, around audit, and around clear processes is what will ideally change the culture for the better.
Mm-hmm. And how is the whistleblower at the centre of this, Nurse A?
She's angry, actually. I mean, I said to her, this report must feel like vindication. And she doesn't feel vindicated by it at all, because she's so bruised and tired by the fight, the decade-long fight that it took to achieve this, and also through what she experienced, that she doesn't think a few bits of paper, 40-something, in that report will change anything, that it's such a systemic cultural issue that she's not confident that this report will change anything. But she does express some hope that it's hopefully going to reignite a discussion around these issues, and that it might bring awareness to, a new generation of women in these circumstances who might understand their right to informed consent as a result of her fight.
I think one thing that disturbs me, as a journalist but as a patient, is the idea that this nurse went through this process, and at one point she was told by the hospital, we can't provide you a safe environment. They put her on paid sick leave for a year, was it? Mm-hmm. Because they couldn't provide her a safe environment, if I understand right, because the surgeons especially were so against what she was telling them to do. Would that not be the point where they would go, okay, what is the issue here? Well, you're saying XYZ. These surgeons need to follow those rules. I mean, the rules were already in place.
Uh-huh.
What is going on in that culture that didn't happen?
Yeah, and I haven't interrogated that part of it particularly, but it does at face value seem like is something really problematic. I mean, I have asked Te Whatu Ora about this, but this is, going back a few years now, and they can't really answer the specific questions, nor will they comment on individual employment matters. But it's exactly that. She was called into a meeting in 2020 and told that they couldn't guarantee a safe workplace for her because of the amount of abuse that she was continuing to experience, and she was paid to stay home for a year. Now, it does seem to me as though she wasn't, the problem there. It was the abuse that was the problem. So paying her to stay away from the workplace versus teaching the people who are doing the abusing that they shouldn't have been would have seemed a more sensible approach potentially. And that ultimately it led to her retirement 9 years early, in a system where we need qualified, experienced, productive, smart operators. And we lost one because we didn't want to hear what she had to say.
That's all for today. The Detail is a newsroom production supported by RNZ and New Zealand On Air. This episode was engineered by Jeremy Veal and produced by Alexia Russell. Thank you to Paula Penfold and Monique Jonas. I'm Gwen McClure. Ka kite anō.